Hello, my name is Shelby. I'm going to be your nurse today. Just give me a moment while I get started. So I'm washing my hands, and I'm going to close this curtain for privacy. All right, so can you tell me your name?
Tom Johnson,
And can you give me your date of birth?
January 3rd, 1989.
All right, I'm going to confirm that with your wristband here. Okay. So your doctor has ordered a head-to-toe assessment for you, and I'll be performing that today. Do I have your permission and consent to proceed?
Yes.
All right. So I'm going to don gloves. And what do you prefer to be called?
Tom,
All right, Tom. Can you tell me where we are?
the clinic,
Okay. And what are we doing?
a head-to-toe assessment,
And what day of the week is it?
Thursday.
All right. And can you tell me the current vice president?
Mike Pence.
All right, very good. The client is alert and oriented ×4. So can you tell me on a scale of 0 to 10 what your pain level is?
0.
All right. So I'm going to take his temperature. Go ahead and open for me. I'm going to place this under your tongue. Good. And open again. All right, his temperature is 97.2. It was taken orally under his tongue, and his oxygen saturation is 99%. I have that information here in the chart. And his blood pressure, I'm going to take that. Do you check your blood pressure at home?
No.
So you're going to feel just a little bit of pressure as I squeeze this here. Okay. His blood pressure is 127, 74. His respirations are 17 breaths per minute. And I'm just going to check your pulse here. And his heart rate is 82. Okay. All right, Tom. So I'm going to inspect your skin here. His skin color is fair. Okay. There's no signs of distress. He seems to be relaxed. He is not exhibiting any psychomotor restlessness, and I'm taking into consideration any cultural considerations. I don't see any signs of abuse or neglect, and he's appropriately dressed for his age, and he's well groomed. I'm not detecting any odors, and for his weight and height, he seems to be getting regular meals, and based on his BMI, which is under 25, that is also indicated that he should be getting regular meals and eating normally. His movements are purposeful, his posture is erect, and he's calm and cooperative. He's making eye contact, he's answering appropriately, his speech is normal, and I don't see any IV sites or SCDs or any mobility aids. But if I did see an IV site, I would check it for redness, for tenderness, for edema, pain, and I would note the rate and solution infusing. So just bend forward for me. I'm just gonna look at your scalp. So his hair is healthy. There's no infestations. There's even distribution of his hair. And if he had a beard, I would inspect that too, but he just has some scruff here. Okay, so I'm gonna look at the skin on your back as well. Okay, good. And your arms. Okay. And I'm also going to check the temperature of his skin. The dorsal surface of my hand is most sensitive to temperature. The palmar side is most sensitive to vibration. So I'm feeling temperature here. There's equal symmetry of temperature in each location. I feel warm. His skin is intact. There's no breakdowns. There's no signs of abuse. And there's no lesions. So he has leg hair, and this is present even on the extremities. If his skin was shiny, or if there was no hair present on the feet, that could be a sign of arterial insufficiency. But I see an adequate amount of hair all over the extremities. Okay, so some other important skin conditions to consider are erythema, which is redness of skin, and it's usually surrounding a localized wound. It indicates inflammation, rash, or vasodilation. Also, jaundice is yellowing of the skin or mucous membranes. This usually indicates a liver dysfunction, and the following terms are examples of vascular lesions. The petechiae is a 1 to 3 millimeter size lesion. It's usually flat and deep red colored or purple. The ecchymosis varies in size, usually purple changing to green or yellow. It's also flat. Decubitus ulcer is the former name for a pressure ulcer. The decubitus ulcers form when prolonged pressure to the skin over bony prominences causes damage to the underlying tissue. So I'm going to check his skin turgor. It has good elasticity. The turgor is brisk. Skin tinting is a sign of dehydration and occurs when the skin doesn't return to its position after being pinched or elevated. The skin tinting would mean it would remain elevated like a tint. All right, I'm going to inspect his fingernails. They're light pink, the nails. The nail bed is smooth and flat. There's no clubbing. Clubbing of the nails is a sign of chronically low oxygenation. And I'm going to check the other hand. Nice, smooth nail beds, pink. Very good. Okay, now I'm going to check capillary refill. And I'm going to apply pressure here. Capillary refill provides information about circulation to the periphery, and his cap refill is less than 3 seconds. All right, next. So I'm gonna palpate the 8 pulse sites now, and I'm gonna palpate them bilaterally at the same time so I can make comparisons. And the carotid pulse site, I'm not gonna palpate that bilaterally because it can disrupt blood flow to the brain and cause him to pass out. So I will do that one at a time. All right, so go ahead and face me. This is the temporal pulse site. And tilt your head back. This is the carotid on the right side. And the left. And this is the brachial pulse site. The radial. And then go ahead and turn around this way for me. And I want you to lay all the way back. Very good. I'm just gonna put some pressure here. This is the femoral pulse site. And then sit up for me again. And come a little bit closer to the edge. And these are the popliteal pulses. And then I'm going to palpate the final pedal pulses. The dorsalis pedis pulse is located on the dorsum of the foot. I'm going to do both of those at the same time. And the posterior tibial pulse sites. So I'm assessing for strength and equality of the pulse. All of the pulses are palpable and all of them have a 2+ brisk amplitude. And they're all equal bilaterally. If I couldn't detect a regular pulse, I would check it for a full minute. Otherwise, if it's regular, I can check it for 30 seconds and multiply it by 2. So next, I'm going to have you lay all the way back again for me, Tom. And then you can take your shoes off again. Okay, and then scoot a little bit further this way. So next I'm going to check for Hohmann's sign, and this is a test that assesses for DVT, deep vein thrombosis, in the lower leg. So I'm going to manually dorsiflex his ankle and see if he experiences any pain or tenderness. Do you feel any pain or tenderness?
No.
Hohmann's sign is negative. Okay, and then scoot back just a little bit more. Very good. Okay, so I'm checking the lower extremities for edema, and I'm checking over the bony prominences, which is the medial malleolus. And I'm applying pressure over the bony prominence of the medial malleolus for at least 5 seconds. Okay. And then I'm checking over the shin and on the dorsum of the foot. So the depth of pitting determines the degree of edema, and there's no peripheral edema. Pitting edema responds to pressure and leaves an indentation in the skin, and non-pitting edema responds to pressure but results in no indentation. So now moving on to the head, ears, eyes, nose, and throat part of the exam. Just by observing his face, I can see that it's symmetrical. There's no facial drooping, and the skin has a nice complexion. I don't see any scales, nodules, lesions, or breakdown. I also don't observe any acne, pustules, or comedones. And his eyes, I'm going to use my pen light to assess the eyes. And the pupil size is 3 millimeters. And the corneas and lenses are clear. His irises are both blue. The pupils are round and equal in size. The sclera is white. I'm going to pull the lower lid down so I can visualize the conjunctiva. It's moist and pink. And I don't see any ectropion or entropion. And his eyelids close completely when he blinks. All right, so I'm going to further assess for the pupillary response. So I'm going to shine some light into your eye. Tom, I just want you to look straight ahead. His eyes constrict directly and consensually. And a consensual response occurs when light shines into one eye and both pupils constrict simultaneously, which is what his did. So now I want you to focus on my finger. and his pupils constrict, and I was checking for accommodation. So I would be able to document PERLA in the chart, and PERLA stands for pupils are equal, round, reactive to light, and accommodation. So now I would use my ophthalmoscope and check for the red reflex. I would dim the light so that his pupils could dilate, and I would be sitting across from him like this, and I would be checking to see for the presence of a red reflex, and that originates from the back of the eye. So the red reflex is bilateral. Now I'm going to take my otoscope and I'm going to check his ears. Since he's an adult, I'm going to pull the ear up and back to visualize the tympanic membrane. For children, it would be down and back. There's no drainage. There is some mild cerumen present, but I can still visualize the tympanic membrane. There are no perforations in the eardrum, and the tympanic membrane is pearly gray and almost kind of shiny and translucent. And the cone of light on the right ear is at 5 o'clock position. I'm also going to check his left ear. And I can visualize the tympanic membrane. It's also pearly gray and translucent. And the cone of light is at the 7 o'clock position. There is less cerumen on this ear. And there are no perforations, no drainage. Okay. Now I'm going to touch your nose. So I'm palpating his nose. The septum is slightly deviated. There's no swelling. The structure is firm and stable. And tilt your head back some for me. Thank you. And I'm going to use my pen light here. The nares are patent. As he's breathing, there's no excessive flaring happening. There's no drainage or inflammation. And the nasal mucosa is pink and moist. Okay. I'm just going to put some pressure here. Is that tender? Okay, I'm putting pressure here. Is that tender?
No.
So no tenderness reported on the maxillary and frontal sinuses. All right, so now I'm going to inspect your mouth. So just by looking at his lips, they are pink and moist. I don't see any lesions or any kind of cold sores around the lips. All right, go ahead and open for me. Let's see, so I'm looking at his gums. They're pink and hydrated and healthy. There's no hypertrophy of the gums or recession. All of his teeth are present. Open again. I don't see any signs of decay or any kind of staining that would be unusual. And go ahead and open wide and stick your tongue out for me. And his tongue is midline. And I'm inspecting the oral mucosa on the sides of the mouth, and there's no lesions. The mucosa is healthy. There's no ulcers, no halitosis, and smile for me. He has an even smile. And can you raise your tongue to the roof of your mouth? Very good. You can touch the tongue to the roof of the mouth. There's no tongue tie, and stick your tongue all the way out. The tongue is not restricted with movement. Stick it out a little further. And say ah. I can see his tonsils are present and they are not obstructing the airway. And very good. So close off. Okay. So any pain here? Open wide and close. Wide and close. Any popping or clicking?
No.
Any pain when you opened and closed?
No.
All right, so the temporomandibular joint is most likely in proper alignment. So I'm also going to palpate his neck. Any tenderness?
No.
I don't feel any lumps, masses, or enlarged lymph nodes. And tilt your head back for me. The thyroid gland is present. Go ahead and swallow. Okay, I definitely saw the thyroid gland there. and I'm not detecting any nodules on the gland. So now I'm going to assess your lungs, and I'm going to inspect the anterior and the posterior side of the thorax. I'm looking at the skin. The skin is healthy, no signs of abuse. I'm looking for any possible deformities of the ribs or the sternum, as well as on the scapula and the vertebrae. Skin on this side is just fine, normal, no breakdown. It's healthy, no signs of abuse, and there are no deformities on the anterior or the posterior. So I'm also going to inspect the spine by palpating the full length of it. And the spine is midline, and it has expected cervical, thoracic, lumbar, and sacral curvatures. And I'm also going to look at the sacral area to check for any pressure ulcers. And any unexpected findings with the spine would include kyphosis, which is an exaggerated thoracic curvature, and it's common in older adults. Lordosis is an exaggerated lumbar curvature, and it's especially common during pregnancy and sometimes in toddlers. And scoliosis is a exaggerated lateral curvature, and the spine resembles an S or C shape. So now I'm going to look at his respiratory effort. His respirations are unlabored and regular, and the rate is 17 breaths per minute with a consistent rhythm. He has adequate chest wall expansion. He's not using his accessory muscles, and there's no intercostal retraction. The character of his breathing is diaphragmatic. And the following terms are all classified as adventitious sounds. Rails are crackles, and bubbles, that sounds like a bubbling sound. Rails are synonymous with crackles and bubbles. So they are caused by air moving through fluid in the lungs, and it sounds like a crackling or bubbling and can be fine or coarse. These sounds are not cleared with coughing. The rhonchi are loud, low-pitched rumbles caused from fluid or mucus, and the rhonchi can be cleared by coughing. Wheezes are usually easier to hear on expiration and are high-pitched, almost musical. And the wheezes are caused by air moving through a narrowed or obstructed airway. Stridor is an abnormal sound, and that happens when the airway is narrowed or maybe obstructed due to a blockage, and it's an eerie, high-pitched, turbulent noise. And sometimes it kind of sounds like wheezing, but it's an eerie, high-pitched emission of noise. Choking is caused when an object or food is lodged in the airway, either by ingestion or inhalation. Normal breathing is not possible, so choking is a life-threatening emergency. And absent breath sounds can be due to a collapsed lung, but before documenting this, I would ask him if he's ever had anything surgically removed or any part of his lungs, like a lobe, surgically removed before I would document absent breath sounds. So now I'm going to auscultate your lungs using the diaphragm of my stethoscope. So I'm going to auscultate the anterior and posterior, ideally with clothing removed so I don't get any distorted sounds. I'm going to make sure he's doing a complete inhalation and expiration, because sometimes adventitious sounds are heard on only one part of the respiratory cycle. And I'm going to be assessing for rate, character, depth, and then, of course, any adventitious sounds. So now, Tom, what I would like for you to do is just breathe in and out. And if you get dizzy, just raise your hand and we can take a break. Okay. So I'm going to start on the posterior side. Can you cross your arms in front of your chest? Good. So this exposes more lung tissue because it kind of pulls the scapula apart. So there are 10 sites on the posterior that I'm going to listen to. So go ahead. Every time that I move my stethoscope, I want you to breathe in and breathe out. Okay, go ahead. I'm also going to be aware that the right lung has 3 lobes and the left one has 2 lobes. So that if I hear a certain noise, I'm very accurate at where I'm documenting the location. So now I'm going to inspect and auscultate the anterior. Go ahead and take a big breath in. So that is all 10 sites on the anterior. He didn't have any difficulty breathing. He wasn't coughing or producing any sputum. And there were resonant breath sounds throughout, equal bilaterally, no adventitious sounds. And if he did have bronchi, I would ask for him to cough, and then I would reassess and auscultate again to see if it cleared. Now I'm going to check for costovertebral angle tenderness. And I'm going to locate the 12th rib on the posterior side where it meets with the spine. And I'm just going to put my hand flat against that area. And I'm just going to gently make a fist and thumb. And then I'm going to inch over and do the same on the other side. Any tenderness there?
No.
All right, so he is negative for costovertebral angle tenderness. If he did have tenderness there might be something wrong with the kidneys or maybe some inflammation. Okay. All right, so now I'm going to assess the heart. When performing a cardiac assessment, I'm going to listen with the diaphragm and the bell at all the sites because it's critical to pick up any sounds. And sometimes they can be heard on the diaphragm or the bell. So first I'm going to listen for rhythm, S1, S2 sounds, and extra heart sounds. And I'm going to identify the 5 precordial landmarks. At the second intercostal space to the right of the sternum, we have the aortic precordial site. To the left of the sternum, the second intercostal space, we have the pulmonic site. Erb's point is in the 3rd intercostal space. And at the 4th intercostal space, we have the tricuspid site. And at the 4th or 5th intercostal space, we have the apical site. And this is the point of maximal impulse. So I'm going to listen at each site. Go ahead and lean forward for me. And S2 sounds are loudest at the base of the heart, where I'm starting. I'm at Erb's point, tricuspid, and the apical or mitral. Now for the apical pulse rate, I'm going to listen for a full minute with the diaphragm. And if there's any dysrhythmia, I would check the pulse deficit by comparing the radial pulse and the apical pulse. And the difference between the two is the pulse deficit. So his heart rhythm is regular. There are no dysrhythmias. And the heart rate is 74 beats per minute. There are no lifts, no thrills. And the S2 sounds were louder at the base of the heart. The S1 sounds were louder and easier detected at the apex. And there were no murmurs or bruits. So now we're moving on to the assessment of the abdomen. And I had the client use the restroom before the exam. If you can go ahead and lay down for me, Tom. When was the last time you had a bowel movement?
Yesterday.
Okay. And first I'm going to inspect the abdomen. There is a rounded contour due to some adipose tissue. The umbilicus is symmetric and not inflamed. There's no drainage or anything. And I don't see any bruises or scarring or striae on the skin. Okay. And after inspecting, I'm going to move on to auscultation. because if I were to auscultate last after percussing and palpating, that could alter the vowel sounds. So I'm gonna start on the lower right quadrant and follow the movement of the vowel. I'm hearing some clicks and gurgles. And if I didn't hear any sounds, I would wait for a full 5 minutes before documenting absent vowel sounds in that quadrant. All right, now I'm going to go to the epigastric region to auscultate the abdominal aorta for any bruits. And now I'm going to percuss each quadrant and listen for the tone that's generated, starting on the lower right quadrant. And then I'm going to palpate about 0.5 inches deep. So if he feels any tenderness, I'm going to stop immediately and palpate that area last. So please let me know if you feel any tenderness during this part. All right, so there's no tenderness to palpation. There are no masses, no nodules. He wasn't guarding. The abdomen is soft. And during the auscultation part, the vowel sounds were normal active. I could hear them between 30 and 60 seconds in all 4 quadrants. And there were no bruise or friction rubs detected. Tympany was heard across the abdomen during percussion. And the abdominal aorta, there were no bruise detected when I auscultated there. All right, so you can go ahead and sit back up again. So, when was the last time that you urinated?
A couple hours ago.
Okay. And do you have any difficulty starting a stream?
No.
Okay. And do you experience any pain or burning sensation when you're urinating?
No.
Very good. All right. So his voiding is normal and regular, and I don't see any bedside commode or any Foley catheter, and the urinary control is intact, and that concludes the head to toe assessment. His bed is all the way down, the guardrails, all 3 of them are up, and the head of the bed is where the patient wants it. His call light is in reach. Is there anything I can get for you before I leave?
That's it, thank you.
All right, so I'm gonna go wash my hands and document.